Hi, everyone. Thank you to the organizers for having me. It's really wonderful to be here. We're in Washington, D.C., as you heard. What I'm going to be talking about today is fetal echocardiography and how we use it for delivery planning for fetuses with congenital heart disease with an overarching goal to improve outcome. I have nothing to disclose. So my objective will be first to highlight data that's showing that prenatal diagnosis of congenital heart disease does improve outcome. And there are some specific caveats to that, which we're going to discuss. I'll review the transitional circulation and discuss why this is important for the newborn with congenital heart disease. I'll then review some fetal echo findings that we look for that enable prediction of a difficult transition and risk for hemodynamic compromise at delivery for newborns with specific diseases, and then discuss some of the delivery management strategies and protocols that we've put in place at Children's National. So as a fetal cardiologist, my goal, first and foremost, is to improve detection of congenital heart disease in utero, and this is certainly a big challenge for us in the United States. We can't initiate specialized care unless we know the fetus has a problem. But once we do detect congenital heart disease, the goal becomes to improve outcome beyond what our current practice is. There are certainly fetal care options that we don't have time to talk about today, but I think just as important is the management of our patients in the delivery room with specialized transitional care protocols, and then planned therapies that we can initiate as cardiologists right in the delivery room. So the big question is, does prenatal diagnosis improve outcome for congenital heart disease? And unfortunately, in the literature, there are several studies that suggest a worse outcome after fetal diagnosis of congenital heart disease. But as you look at them, they're limited by their methodology. Most of the time, the fetal diagnosis group have heart defects that are more severe. And then oftentimes, terminations of pregnancy are counted as death. In the postnatal diagnosis group, it is really hard to identify those deaths that occur in local delivery hospitals or even at home. This is a nice study that's now came out a while ago that was a meta-analysis of multiple studies of over 1,300 patients, 22% prenatally diagnosed. And just like all the other studies on first assessment, the mortality was higher in the prenatal group. But the authors acknowledged that the fetal patient data included higher risk diagnoses as well as terminations. And what I thought was interesting was that the fetal diagnosis did not assure optimal postnatal care. So then on a second look, that included only patients with standard risk and intent to treat. And then what they defined as optimal delivery room care, the mortality was in fact lower in the prenatal diagnosis group. If you look at the odds ratio for the individual studies, as well as the overall meta-analysis, there was an improved outcome in those prenatally diagnosed. So this leads me to then come to the conclusion that it's not just the diagnosis of congenital heart disease, but then what we do after, the management, that's important for outcome. So what do we need to think about as we go from fetus to the postnatal circulation, and what are the postnatal considerations for transition in the delivery room? Well, first and foremost, there needs to be an initiation of respiration and ventilation. The airway has to be patent, the lungs need to expand. And obviously, this is what our neonatology colleagues are specialists at. Any abnormality of the airway certainly would cause trouble in the delivery room. But just as important are changes in the circulation and the hemodynamics that come with being born. First, there's closure of the fetal shunt pathways, the ductus venosus, the ductus arteriosus, and then the foramen ovale actually closes right in the delivery room. There's a shift in the right and left cardiac outputs from a circulation that we say is in parallel to a circulation in series. There's an increase in systemic vascular resistance that comes immediately with clamping the cord. And there should be a decrease in the pulmonary vascular resistance with initiation of respiration. So if that transition in any way affects the heart defect, or if the heart defect affects the transition, then we at least have to think about specialized care in the delivery room. So who needs specialized care? And this is something that I've been thinking about for a lot of years. When I got to Children's in 2004 and realized we didn't have a delivery room on site, I really wanted to think about what could I do as a fetal cardiologist to identify those babies who would struggle in the delivery room. And what we did was put together a transitional care risk for delivery room level of care. And we use this prospectively and have several reports in the literature showing that it really does work. It has become part of the fetal cardiology guidelines through the American Heart Association that were published in 2014. So looking at it, there are 4 levels of care for us. Honestly, in some institutions that have a delivery room and a neonatology unit right together, 3 and 4 can kind of go together. Level 1 are the low-risk patients that we really expect no instability. Most of these patients can go home and be seen as outpatients, get their surgery later. Level 2 are the medium-risk patients that will need an operation before they go home, but we do not expect instability in the delivery room, and this is mostly the ductal-dependent lesions. And then the 3s and 4s, the high and the really high-risk patients, are those that will have significant compromise, right, with cord clamping. When we think about improving outcome, certainly with delivery room management changes, what we're really looking at are these very few number of patients, but the sickest patients in the highest risk category. So let's just go through a couple of examples. First, the left to right shunt lesions. These are ASDs, VSDs, and even some more complicated defects like AV septal defects, AV canal defects here, where you can see the 4 chambers of the heart, the big hole right here in the middle with a single common AV valve. And then the color really shows that there's no flow going across these holes in the heart. And so these patients will actually be very well in the delivery room and actually for weeks after birth because the shunting doesn't happen until the pulmonary resistance falls, which can take weeks. So these patients usually can go home and then be seen as an outpatient. Another diagnosis that falls into this category is a little bit more complicated, truncus arteriosus, where here you can see the normal 4 chambers, but in this picture here, a single artery that gives rise to the aorta and the pulmonary artery. And then down here, the single outlet, which is the truncus. This is actually a lesion that does depend on shunting. And again, stable in the delivery room and maybe even in the first week of life. So these are what we call our low risk or level 1 diagnoses. Tetralogy, most common cyanotic congenital heart disease. We all know 4 things. 3 of them are present in the fetus. First off, as we start to look, the 4-chamber view is normal. This is why sometimes obstetricians don't see this diagnosis in utero. But just by angling a little bit superior, you can start to see a big hole in the heart. And then a little bit further, this is the aorta that overrides the interventricular septum. And a little bit further superior, we can see the pulmonary outflow tract. And this here is the pulmonary valve, doesn't look normal, so there's pulmonary stenosis. We all know there are pink tets and blue tets. Pink means the oxygen level is okay and they can be repaired electively. Blue is a ductal-dependent pulmonary blood flow lesion. So how can we decide whether this baby is low risk or medium risk, needing prostaglandin and transfer for an operation? There's several studies in the literature that tell us as fetal cardiologists what to look for. We can look at the size of the valve. But more importantly, actually, what we found is looking at the ductal flow pattern. In the fetus, the ductus should flow away from the lung, so right to left. And if we see that reversed flow pattern, which is this little red jet, the left to right shunt into the pulmonary artery, this suggests that the pulmonary outflow is inadequate. So suddenly, just this little red jet tells me that this is a ductal-dependent lesion. We're going to need a neonatologist to put a line in and start some prostaglandin, and this baby's going to need surgery. So now let's just move on to the high-risk diagnoses. Thank goodness there aren't a lot of them, but these can be the sickest kids right from the time of birth. Here's the list from our work in the first paper that we published in 2013. We can identify which of these subgroups of patients with these specific defects will be sick and be assigned a higher risk diagnoses. And most importantly is the care plan that we put in place once we decide or identify that these patients are likely to get sick in the delivery room. So let's look at some examples. This is hypoplastic left heart syndrome. This is pretty easy to see. The left side of the heart is missing. This should be the left ventricle. The mitral valve is atretic. But what makes this one ductal dependent is actually, this is the aorta, this little tiny 1 millimeter blood vessel, and flow is going away from the spine, so reverse flow in the transverse arch from the ductus arteriosus. So this is a ductal dependent lesion. Obviously, this one needs prostaglandin and transfer, so this is automatically a medium risk patient. But in about 10% of babies with hypoplastic left heart syndrome, there's an additional restrictive or intact foramen ovale that can potentially even get worse at the time of birth. And so now when we go back and try to look at the atrial septum, it's actually really hard to tell if there's flow going across or will that connection be adequate. So is this a medium or high risk patient? Those hypoplastic lefts with an intact atrial septum get sick very fast. Just as soon as ventilation starts, there's blood that goes into the lungs and then it can't get out. So you have rapid pulmonary edema. And unless you do something pretty quickly, you're going to get sick, acidotic, and hypoxic very quickly. So the literature tells us to look towards the pulmonary vein flow, which are representative of left atrial pressure in the fetus. And it's this pattern here in the bottom that suggests that baby's going to be in trouble. So this baby did have that pattern. And so this is one of our high-risk diagnoses. So what do we do for this at Children's National? The delivery room care. First off, easy, start prostaglandin. Our stabilization strategy is to really take total control of the circulation and to try to maximize oxygenation with intubation, sedation, and then paralysis right in the delivery room. Oxygen is used sparingly. We use it to keep the O2 saturation in the preductal, so in the arm, somewhere around 70 or 75% if possible. But really what needs, and then we have ECMO backup. The ones that have an intact atrial septum can get very sick very quickly. Ultimately, we prepare for the cath lab to happen as quickly as possible, and we go from the delivery room to the cath lab straight away. Here is a picture of a postnatal atrial septum intact. You can see in this cartoon why, if this was intact, why that blood just couldn't make it back to the circulation, why this kid would get so sick very fast. We use echo-guided and fluoroscopy-guided intervention. This is a very specialized blade catheter that can be put across the atrial septum to improve that connection. And then post-procedure, we have a relief of that pulmonary venous obstruction. Next one on the list that's a terrible disease is Ebstein's anomaly. It's an anomaly of the tricuspid valve. This tricuspid valve is very dysplastic. The septal leaflet is stuck. The heart is huge compared to the chest. And the blood's really just swirling around in here, so it's not getting to where it needs to go. In a multi-center study that we participated in that originated in Boston that was led by Dr. Freud, mortality in the current era was 45% overall, with a significant in utero death of 17%. Predictors of mortality were early diagnosis, a big tricuspid valve, the presence of effusions or early hydrops, and the presence of pulmonary insufficiency. And non-survivors had low birth weight and early gestational age at delivery, usually because they were hydropic, and then pulmonary insufficiency at any gestation. So that's an important marker for us to look at. So here now, looking at, in this particular patient of this pulmonary outflow, there is no forward flow. This red represents significant pulmonary insufficiency. So this certainly is a high-risk patient. So what do we do for these kids? Well, it's up to us in the fetal cardiology world to try to decide if the pulmonary valve is atretic or just not opening. If it does open and there's pulmonary insufficiency, this is what is called the circular shunt, which is backwards flow across that pulmonary valve, backwards flow across the tricuspid valve, and the blood just kind of gets stuck in this path and doesn't make it to the body. So in this instance, we think the ductus is at least partially the problem, so no prostaglandin is initiated, versus those that have true pulmonary atresia, we do start prostaglandin in the delivery room. The specialized strategies for ventilation certainly, again, include getting total control of ventilation to maximize oxygen delivery. intubating, sedating, and paralyzing. And we want to try to decrease the pulmonary resistance if that pulmonary valve is open, and at least in the delivery room, until we get to the ICU, where then a reassessment is made. We use 100% oxygen and then consider using nitric oxide in the delivery room, again, to rapidly help that baby transition. ECMO is used for this as backup as well until we can figure out what surgical procedure is needed. Another one that causes trouble in the delivery room is tetralogy with absent pulmonary valve. On the inside, it's a tetralogy with a big hole in the heart and an overriding aorta. But as you angle up towards the pulmonary outflow tract, it's not a thick, small pulmonary valve, but actually a dilated annulus with a valve that's really not opening or closing, and then really massively dilated branch pulmonary arteries that affect the lungs. There's not usually a ductus in this disease, which is interesting. And then obviously the biggest problem is significant pulmonary insufficiency, which is this red jet here. So the mortality in this group, looking at multiple studies in the literature, is pretty high, between 40 and 70%. But what's really interesting is that there are two very distinct subgroups that get reported time and time again in multiple different papers. About half of these patients have no respiratory symptoms in the delivery room and actually are straightforward tetralogy patients that can be repaired electively. And then the other half have significant respiratory compromise with CO2 retention and acidosis and hypoxia right in the delivery room. And we think it's obviously due to multiple factors, but tracheobronchial malacia and lung hypoplasia or hyperexpansion, congenital lobar emphysema with air trapping. The mortality in the literature, single center studies, eye drops, any right or left ventricular dysfunction. If there's an associated genetic abnormality, this is often associated with microdeletion on chromosome 22. But interestingly, it's not the size of the branch pulmonary arteries in these single center studies. And so it's not a direct correlate of the big pulmonary arteries are pushing on the tracheobronchial tree. However, if you have respiratory symptoms at birth, you're more likely to die. And so then our challenge as the fetal cardiologist is to try to predict which one of those babies are going to have respiratory symptoms. So we took this challenge on at Children's National, and this is one of my fellows put together a multi-center study that was published this year. 19 centers. We had 78 patients with an intent to treat, so that took out the terminations. 71 of those survived to birth, so a 9% in utero mortality. And again, that 50-50 rule sort of held up with 53% having an elective repair with an overall good survival. And then the other half either died without intervention or surgery because they were just so sick. 30% of them required emergency surgery to try to open up that outflow tract to take the pressure off the lungs. With a 71% survival. Echo predictors of death included a big heart, moderate or severe right-sided dilation, any left-sided dilation, RV or LV dysfunction, and a large pulmonary valve Z-score, which really is a correlate for the amount of pulmonary insufficiency. Interestingly, we as well found that the size of the branch pulmonary arteries didn't matter. And we did try to look at lung findings that you would see on fetal echo. So it's really how the lung affects the heart. Mediastinal shift and left or right lung enlargement or compression were in fact associated with poor outcome. So now we take this same patient and we kind of ignore the heart and try to look at the lungs. It's a little bit of a challenge on ultrasound. Maybe this lung is a little bit brighter than this lung. This lung looks bigger. Is this lung smashed or is it hypoplastic? So for this particular patient, we used fetal MRI. And the only surprise was how easy it was to see that the lung was really abnormal. So here you can see a massively dilated right lung that's full of fluid. The left lung is the sliver back here. The heart is the black in the middle here. And you can see this big right lung, hypoplastic left lung. We were even able to see deviation of the trachea on this study. So this fluid-filled lung will become an air-filled lung with air trapping and CLE. What we anticipated. So certainly this is a high-risk diagnosis. That's exactly what happened. This kid deteriorated rapidly and had to be cannulated onto ECMO. We had it ready go right in the delivery room. So what do we do for these kids? First off, you can try prone position for the ones that aren't quite so severe. Sometimes pulling the pulmonary arteries off the airway can help. But the ones that we really expect to be sick, again, intubate, sedate, and paralyze to control that ventilation. The goal is to minimize air trapping. The last thing you want to do is blow a pneumo in addition to the other things that are going on. You want to try to decrease pulmonary resistance, again, oxygen and nitric oxide, and we always have ECMO backup for these. Transposition, this one's my favorite. This is the only leftover diagnoses where the pre-op mortality and morbidity is higher than post-op, and it's really the foramen and the ductus that contributes to the problem. The literature, single-center studies tell us what to look for the atrial septum and the ductus. This is a restrictive foramen with a tethered septum primum. The blood is just swirling around here on the fetal picture. This is what we call a hypermobile atrial septum. It's flipping back and forth. That's due to elevated left atrial pressure in utero. And here, the aortic and ductal arch. This ductal arch measures small. And then flow in the ductus should be only in one direction, but we can see that it's bidirectional. So certainly all these findings suggest that this baby's going to be sick in the delivery room, require a septostomy. These are high-risk patients. But the trick with and the difficulty with transposition is that if you see these features, it's very specific for difficulty in the delivery room. But unfortunately, if you do not see these features, you have about a 50-50 chance that the baby will be sick. So those aren't very good odds. This is an example of a case that I reported a long time ago now as a young attending. Showed up in my office at 34 weeks. Actually, in the OB's office, there was fetal distress with abnormal, horrible-looking heart rate tracing. And as they were prepping for a C-section, we took a quick look. The heart's dilated. The foramen is intact, and the ductus is gone. So this is transposition with the closed foramen and ductus. That results in a very sick fetus and a very sick newborn for sure. This is a really, really high-risk patient. We had ECMO in the delivery room for the section. There was cardiac arrest, right, with cord clamping. We were able to cannulate onto ECMO, and this kid did go on for an arterial switch operation, but unfortunately died from complications relating to pulmonary hypertension. Now looking at, so what do we do for these patients? Well, it's obviously ductal dependent, prostaglandin, that's the easy part. Stabilization strategy, 100% oxygen certainly is useful. You want those saturations to be as high as possible in the preductal area. You want PVR to fall. If they are very hypoxic and we're worried that the septum is closed, we actually do an echocardiogram in the DR. We'll intubate, sedate, and paralyze. And if there's reverse differential cyanosis with marked hypoxia in the preductal area, so saturations on pulse ox of less than 60, we will start nitric in the DR. Again, reassessment once the kid gets to the cardiac unit once we've changed the circulation. Plan for the balloon septostomy. It can actually happen in the DR, in the ICU, or in the cath lab because we can do balloons using echo guidance. So here's an intact atrial septum with just a tiny connection down here. Pay attention to the balloon that's in the left atrium. It's accessed via the femoral vein. Push the balloon down across the foramen, blow it up, and then pull it across, and then an open atrial connection. Total veins, not much to say. There's multiple kinds. If you want to know where the pulmonary veins insert into the systemic circulation, but the important part for the delivery room is, are these veins obstructed or not? And so can we figure that out on fetal? This is a heterotaxy patient with a single ventricle, but if you look, this little red thing is the pulmonary vein trying to get to the heart. It doesn't quite make it. It goes down below the diaphragm and circles around to enter the portal system. Usually the infradiaphragmatic veins are obstructed, but that's not always true, and supracardiac veins can be obstructed as well. So is this a low or high-risk patient? Again, we use flow patterns. This report from a single center tells us to look for this. And that's exactly what we found. So this is high risk. There's not much medically that you can do for these patients. These patients need surgery. So whether you decide to cannulate onto ECMO or to go straight to surgery is center dependent. Fetal arrhythmias, the tachycardias can be primary arrhythmias leading to secondary heart failure or primary heart failure from cardiomyopathies leading to secondary arrhythmias. Either way, tachycardia and hydrops, you can see the fluid in the abdomen and around the lungs. That's a bad sign for an increased risk for death, both prenatally and post-delivery. The bradycardias, in particular, AV block, can be related to SSA, which is the connective tissue lupus or Sjogren's. It can be associated with endocardial fibroelastosis, so scarring of the myocardium, which leads to heart failure. You can also have very severe congenital heart disease with heterotaxia and left atrial isomerism that can cause a cardiomyopathy. You can see how thick the heart is, and AV block. Factors that influence outcome is if you're forced to diagnose to deliver these babies early, because they're hydropic, the outcome is poor. Certainly, if there's associated congenital heart disease, you can't control the rhythm in utero. Either it's too fast or too slow. That certainly influences the outcome. And as I said, hydrops and the need for a premature delivery. So these patients certainly will be sick in the delivery room, and there needs to be a strategy put in place to somehow deal with the rhythm, whether it's cardioverting or using medications for the fast rhythm, speeding up the slow rhythms with beta agonists like epinephrine or isoprel, or even pacing in some instances. So back to my study, can we predict delivery room care? This is 8 years worth of experience. We had over 8,000 fetuses, 7,400 were normal. We do a lot of screening. Were we good at our screening? We only missed 4, so it was a less than 0.01% miss rate. 3 of the 4 had coarctation. That's a tough thing for us to diagnose in utero. More importantly, the ones that we assigned a level of risk, whether it be 1, 2, 3, or 4, how do we do with that? The level 2s are important because those are the ones where I say, you can deliver where a neonatologist is present, but the cardiologist does not have to be present. In this group, we had 260. There were 7 that we missed, and these all were transpositions. So this early in the experience where we assign these levels of care, we tried to use the parameters that we saw in utero to predict foramen closure. One of them got very sick, and it only took that one patient for us to realize that you just really can't trust what's going to happen in the delivery room for transposition. So no matter what the fetal study shows, you have to be prepared to intervene and open the atrial septum. For the 3s and 4s, we were pretty much on target with what they were when needed. This all got put together in the HA scientific statement, the lesions, what to look for on fetal, and then what to do about it in the delivery room. And again, the expert consensus was that all fetuses with transposition should be considered at risk. So can we do any better? What we're doing now is called hyperoxia testing. So if you give a mom 100% oxygen in the 3rd trimester, you'll actually decrease the fetal pulmonary resistance and increase pulmonary blood flow. And this simulates sort of what's going to happen in the delivery room. This is our proof of concept publication that says that we did find it useful for Ebstein's to say, will that pulmonary valve open? For the total veins, is that vertical vein going to be restrictive or obstructed? How about the egress from the left atrium and hypoplastic left heart? And then in transposition, gives us some idea on the foramen and the pulmonary resistance. So here's an example. This is a transposition fetus that the red shows open foramen ovale flow, and then with just 10 minutes of oxygen, the foramen closed. So this certainly was a fetus that we thought would be at risk for atrial septal closure. Okay, just to finish up with all of our other subspecialists for the obstetricians, there's no data to support the benefit of a C-section or vaginal delivery with rare exception. fetal monitoring, there's no data to support any additional monitoring beyond what is typically done for all pregnancies. The delivery timing, however, does matter. Multiple studies, this one from the STS database suggests that the best time to deliver a baby with a significant heart defect is after 39 weeks. This is hot off the press. I'm very proud of this. This is an effort that spanned our disciplines. Dr. Berger, who you're going to hear speak, as well as our neonatology colleagues, Dr. Short's colleagues in neonatology, we all got together to say, how can we standardize our delivery room practice for these very high-risk diagnoses? So obviously, the general approach follows standard neonatology guidelines. You certainly need positive pressure ventilation for apnea or poor respiratory effort. You do need to start chest compressions for significant bradycardia or asystole, unless there's a conduction abnormality that we identify. So if there's AV block with a heart rate of 50, you don't want to start chest compressions. As far as what the targeted oxygen level should be, that's the challenge, and whether to use supplemental oxygen. So we do know there's a transition over the first 10 minutes and what oxygen level should we shoot for or aim for. But there's a big question mark when we're talking about congenital heart disease, and this is where the fetal diagnosis will help us to interpret these oxygen levels on the anticipated diagnosis-specific physiology, and then use supplemental oxygen as needed with aiming for that targeted saturation. We put together this nice summary table that looked at those different diagnoses. Should you intubate? Should you use oxygen? Should you sedate or use neuromuscular blockade? Do you need an echo in the delivery room? How about prostaglandin? What about lines? With a goal being to get out of the delivery room as quickly as possible to where care can be initiated for these high-risk diagnoses. We also put together checklists for specific diagnoses. This is an example of one of them. Usually this checklist is printed and put it right in the resuscitation room. Our transport team carries it. Now for the higher risk diagnoses where the cardiologist as well as other specialists need to be present, we do coordinate delivery room care with flow diagrams. This is from one of our later publications, and create these flow maps really saying where people should be and what their job is at each stage in the resuscitation. So how do we do for these really terrible defects? Again, this is from one of our earlier publications, 34 fetuses with very, very, very severe disease. The gray is what we anticipated needed to happen. We were right pretty much all of the time on what needed to happen. What's important is for these awful diseases, the delivery room survival was 100%, and survival to discharge was 83%. Other things we looked at the time to care and time to the intervention, certainly if we coordinated it, it happened faster, and there was an effect on oxygenation. Looking at other places where there's different resources available, the study that came out of India of 119 with critical heart disease, 33% were prenatally diagnosed. They had a 10% mortality, with 9 of those dying preoperatively. In the prenatally diagnosed group, there was better pre-op hemodynamics and a lower transport risk index of stability. Lower preoperative mortality in the prenatally diagnosed group, meaning that coordination of care to get them to what they needed sort of improved survival. And in the group that were postnatally diagnosed, there were 7 out of those 10 died because of injury to their organs precluding surgery. In another resource utilization, this is Toronto, so big city within kind of a large country where referral is to 2 main centers. 129 diagnosed with ductal-dependent lesions, half were prenatally diagnosed. They were admitted faster if they were prenatally diagnosed, but they had a lower lactate. They were less likely to be ventilated or require vasoactives. They were less likely to arrest before surgery and less likely to die before surgery. So again, the fetal diagnosis allows planning of care starting right in the delivery room. So in summary, the fetal diagnosis of congenital heart disease, I do think improves outcome. We need to understand the circulation and plan for transition in the DR, and certainly a team approach, including cardiology, ICU doctors, neonatology, transport. All of us are needed for a successful outcome. So with that, I will stop. Thank you very much for your attention.